Thank you, Mary, and Mike, thank you for accepting the introduction from, it was Steve Mayfield, actually, who is a professor here as well, who had been reading some of the stuff on my blog and suggested that part of what I write about might be suitable for a discussion like this. So, before the talk, Mary had requested I give at least some explanation of why I find this topic compelling, because it's actually quite circular. I am a physician, but I don't practice medicine in a traditional or clinical sense anymore. In fact, as soon as I completed my residency, I left. So I did my residency in general surgery at Johns Hopkins and my fellowship in surgical oncology, and then just had a real change of heart and decided I didn't want to practice clinical medicine. So I joined the consulting firm McKinsey & Company and actually wanted to get as far away from healthcare as possible. So while at McKinsey, I worked in credit risk modeling and banking services. Nevertheless, I've meandered my way over to what I'm doing now, which, as Rachel, one of my colleagues, has alluded to, is starting a nonprofit organization called the Nutrition Science Initiative, which we, at least in the eyes of the IRS, started in January, and more formally and publicly will probably be launching in the next 4 weeks. And I've co-founded this organization with a gentleman that some of you may know, Gary Taubes, who's a science journalist, and for whom actually much of the content in this presentation really comes from a lot of the research Gary did between the period of about 2000 and 2005. On a personal level, as evidenced by the fact that my trainer is here, I'm a sort of person who's always been physically active and always sort of valued exercise and whatnot. But interestingly, sometime around my 30th birthday, things sort of started to change in my life personally, and I just turned into a really sort of chubby person, which was quite frustrating to me because I was sort of doing everything I was told. I mean, I think it's one thing to say, gosh, I'm 50 pounds overweight and I'm eating M&Ms and sitting on the couch all day. It was another thing for me to be doing very long swims and bike rides and eating my skinless, boneless chickens and, not eating eggs and doing all the right stuff and yet becoming, on the cusp of obese and certainly having what is going to be known as, some of you know, metabolic syndrome, which is a cluster of 5 symptoms, which really are the central theme of the diseases that we see related to obesity. And so through my own work and personal experimentation largely, I came to appreciate that the dietary recommendations as they were formally laid out did not apply to me. In fact, the exact opposite applied to me. That led me to the discovery of the work of Gary and others, and ultimately a friendship with Gary, and I came to realize that I may not be unique. In fact, it may be that as much as 60 or 70% of the American population also doesn't seem to respond too favorably to the formal recommendations set forth, which made me ask broader questions, and that kind of leads to the talk today. So, if it's all right with folks, I'd like to try to get through the talk and then go to a Q&A after. We've got plenty of time, and I'm more than happy to spend as much time as folks have. The reason I say that is not that I'm not used to being interrupted. I have a 4-year-old daughter, so I'm very used to being interrupted. But the talk is actually, it's as you can tell, it's a history lesson. We're going to cover 60 years, but I don't do it in a perfectly linear fashion. I'm going to jump around a little bit. It's the only way I can tell the story. So with your patience, please allow me to do that, and I promise we can come back to addressing everything. So in the words of one of my surgical mentors who, when doing long operations, used to always remind me, Peter, it's fast on the straightaway, slow on the curves. So we're going to do that today. There's going to be some parts of this which I'm going to whip through really quickly, and there's going to be other parts when I slow the car down and I really want to point out a tree on the side of the road. So if you wonder where the tempo is coming from, that's it. So I alluded to this at the beginning. I have personally an enormous interest in this problem, not just as someone who was formerly overweight, but more importantly, I think, now that I've come to realize the social and economic toll of obesity and its related diseases. And I sort of liken the United States to a cruise liner that's trying to navigate its way around icebergs. And every one of us probably has an interest and a deep knowledge about what some of those icebergs might be. In other words, these are the things that are really going to get in the way of the cruise liner. So it could be, energy security, it could be pension overhang, it could be educational mishaps. But I personally believe, and I believe there's more than sufficient data to suggest this, that the closest iceberg to us is actually healthcare, is the cost of healthcare. And it's related to this. So let's just go over some of the things that I think most people are probably aware of. In the United States, the rate of obesity has really skyrocketed in the past 40 years. So since the time I was born, we've gone from a prevalence of obesity of 15% to about 35%. Perhaps more disturbing than that is not just the rate of growth of type 2 diabetes, which is very closely linked to obesity, but more importantly, what the derivative looks like. In other words, on the obesity curve, we're actually seeing a somewhat flattening of the curve. Some people find solace in that, but no one is disputing that the derivative on the diabetes problem is not just growing, but it's increasing exponentially. And so why is this happening? Well, you know, if you'd asked me this question 5 years ago, I would have said it's happening because Americans are fat and lazy, right? Even though I was sort of one of them. I wasn't lazy, but I was certainly overweight. And I you know, one of the things that was most humbling to me when I first read one of Gary's books, and it all sort of came together that this wasn't just about me anymore, this was kind of a more global issue, was this realization that back, you know, when I was clinically practicing medicine, how often subconsciously I sort of judged people who were diabetic and overweight. And it wasn't a judgment that I don't think ever came through in the way I interacted with them, but it certainly existed in the back of my mind, which was, if you would just stop eating so much, you know, you wouldn't be here having to let me amputate your leg. If you would just stop eating so much, I wouldn't have to do X and I wouldn't have to do Y, and you wouldn't have to cost the healthcare system Z. But let's take a look at that. So if you look at the NHANES database, it shows the consumptive pattern of Americans going back for 40 years. And you'll notice that carbohydrate intake has increased steadily over that period of time, while fat intake has declined commensurately, and protein intake has remained largely flat. If you look at another database, the FAO database, so this is the Food and Agricultural Organization, they give you an even more granular breakdown of what happened over that same period of time, which is that grain consumption specifically increased by 39%. The consumption of butter and eggs fell by about 38%, and the consumption of all animal products fell by 13%. So we can certainly take comfort in knowing something, which is when the American people were told to do something, they actually did it. Now, what I'm not showing you here is that overall caloric intake has increased, and I have no doubt that we will have a discussion about that over time, but the caloric increase in and of itself does not actually explain what we're seeing. Now, you'll notice that in parallel to the change in macronutrient composition, we also witnessed a stunning rise in the level of obesity, and these are the same data that I showed you a second ago, except they're broken down by subcategories. So now you can actually see that virtually every demographic of the population has seen this increase in obesity. And what I'm not showing you here, but is perhaps most disturbing, especially folks in the room who have an interest in childhood health, is that the incidence of diabetes type 2 and obesity in the child population is increasing at an alarming and stunning rate. Finally, I wouldn't be a true McKinsey former consultant if I didn't show you something about the economics of it all. This analysis was carried out by Ed Levine at McKinsey in a large healthcare report that was published in January. This looked at the growth of economic, the GDP growth and compared that to healthcare spending. You know, the United States spends more on healthcare than any country on earth in absolute dollars, per capita dollars, and percentage of GDP. So we spend 18% of our GDP, $2.4 trillion on healthcare. That's about $8,000 per year per person. And I've heard a lot of people rationalize that by saying, well, we're entitled to it. We're the most prosperous country in the world. It's okay. I would argue that would be true if this weren't true. If we were able to match economic growth to healthcare spending, it might be true. Now, I'm saying nothing about the quality of the healthcare we're providing or the disparity of it, but just put that aside for a moment. This is where I come back to my argument about sustainability. That gap is getting wider. It's not staying the same, it's not getting narrower, it's getting wider. So healthcare spending, as you can see, has outstripped economic growth since 1960 by 5x. It's not clear to me how much longer that's sustainable. I've heard others suggest we've got about 15 years to resolve this. Okay, so what we're going to do today is talk about one very specific issue. Now, there are a lot of issues we could be talking about today because tragically the story I'm about to tell you is true for many of the recommendations that people are given. And I contemplated doing this talk at a very high level and going through all of them, and in the end I decided about a week ago I'd rather tell a deeper story and allow you to understand that by extension, the story I'm going to tell you about fat, saturated fat, and cholesterol is actually true in salt, and it's true in a lot of other things as well. So what are the recommendations? Okay, Intakes of dietary fatty acids and cholesterol are major detriments of cardiovascular disease and type 2 diabetes, two major causes of morbidity and mortality in Americans. By the way, about 61 to 62% of Americans every year die of these diseases and their related diseases. In order to reduce the population's burden from cardiovascular disease and type 2 diabetes and their risks, the preponderance of evidence indicate the beneficial health effects that are associated with several changes in consumption of dietary fats and cholesterol. These include limiting saturated fatty acid intake to less than 7% of total calories. So that's what we're told to do. It's what we've been told to do for 40 years, and actually we're doing a pretty good job. American consumption of saturated fat is probably just under 10%, so we're not quite there. Okay, well, let's take a look at the evidence. So the Food Agriculture Organization, the World Health Organization expert consultation paper in 2009 said the available evidence from cohort and randomized controlled trials is unsatisfactory and unreliable to make judgment about the substantiate the effects of dietary fat on the risk of coronary heart disease. Furthermore, there is no shortage of studies, and we're going to go through many of them, but I use this one as an example because it's one of the more recent ones, one of the larger ones, and it's got certainly some of the most prestigious authors on it, that commented in 2010, a meta-analysis of prospective epidemiologic studies showed that there is no significant evidence for concluding that dietary saturated fat is associated with an increased risk of coronary heart disease and cardiovascular disease. Okay, now begins the history lesson. So let's go back to 1951. A couple of really interesting things occurred at this time, really two things. One is President Eisenhower had a heart attack around this time. Now that was interesting because it was a rather public discussion about it. So he didn't have his heart attack in public, but after the president had his heart attack, it became a very publicly open and interesting discussion. And if anyone's read about this, and there was actually an article in the Financial Post about this 2 weeks ago, which some of you may have seen, it went through the whole story in a very elegant fashion. The remainder of Eisenhower's life was a consistent removal of fat from his diet. The poor man, at the time of his death, was eating only Malba toast. So that's one event that occurred. The other event that occurred, completely unrelated to that, but you're going to see there's a recurring theme here, which is serendipity, or lack thereof, confluence of events. The other thing that occurred in the immediate post-World War II time period was the development of a technique to measure something in the blood called cholesterol. So you've all heard of cholesterol, and unfortunately, though it's probably one of the top three things I'm interested in life, I won't, for the sake of time, be able to go into that today. But nevertheless, cholesterol is a molecule in the body that is essential for life. In fact, there are rare genetic disorders where people can't make or absorb cholesterol, and these disorders are fatal in utero, essentially. But nevertheless, we finally figured out a way to actually take all of the particles in the blood, and there are really 5 main particles that carry cholesterol in the blood, but there's a technique that could break them all apart and just count the total amount of cholesterol. Okay. Ancel Keys is a name that may ring a bell to some of you. He was a physiologist and nutritionist at the University of Minnesota. He and his wife, Margaret, visited Italy in the early 1950s and took with them this new technique for measuring cholesterol. And they did just that. They measured cholesterol and fat content of the diet and compared that with 2 different populations. So a group of wealthy people who were eating a higher fat diet and had higher blood levels of cholesterol, and a group of workers in the field who were commensurately not doing that. So these people were consuming less fat, and they actually had lower risk of heart disease and cholesterol. So a year later, Keys presented his hypothesis at the World Health Organization meeting in Amsterdam by saying that fatty diet raised serum cholesterol, atherosclerosis, myocardial infarction. So eat fat, raise cholesterol, get heart attack. That was the thesis. Within a decade, and I'm going to give you a little bit more detail in the middle, within a decade the American Heart Association had effectively adopted this. And they said in a 4-page ad hoc report from an ad hoc committee that included Ancel Keys' conclusion, the best scientific evidence of the time strongly suggests that Americans would reduce their risk of heart disease by reducing the fat in their diets and replacing saturated fats, specifically with polyunsaturated fats. In 1957, Ancel Keys published something called the 5-country study. The 7-country study wouldn't be published for another 13 years. This was a study that became really the blueprint and the staple for nutritional studies. It's observational epidemiology. So these aren't experiments, they're not controlled, you don't manipulate anything, but you follow people either prospectively or, in the case of Ansel Keys, retrospectively, where you look back at data. The 5-country study took countries that had a known disparity in their consumption of saturated fat. So at the top of the curve you had the United States, Canada, and the UK. At the bottom of the curve you had Italy, Japan, and France, and I can't remember exactly which countries made it into the 5-country and not the 7, etc. But the point is there was a very clear correlation. It was a straight line. The countries down here, Japan, Italy at the time, that were consuming scant saturated fat had a very low incidence of heart disease. The United States, the UK, that were consuming fat up the wazoo, dropping dead of heart attacks all day long. And by 1961, Ansel Keys was on the cover of Time magazine saying that the ideal heart-healthy diet should be 70% carbohydrate and 15% fat. Okay, so the competing philosophies. Let's talk about what the proponents have to say about this. We're going to come back to the McGovern report in a little while. That's the sort of informal name. But nevertheless, this commission that was run through the Senate between 1968 and 1977, the conclusion of this was a report that was published, and this report made formal the dietary recommendations that we're going to talk about. And I'll get to that in a second, but the point here is the dogma of the day was we don't have the luxury of time to find out the truth before making policy. So to tie this into the theme of ethics, it's an important question, because sometimes you don't have the time to find out the truth, perhaps, and you have to make your best judgments. But that is formally the position of the United States government in 1977. Of course, the opponents and skeptics would argue the opposite. Without definitive evidence, we don't know if we're right. And I would add, by extension, we don't know if we're doing more harm than good. Okay, so let's take a walk down selection bias lane. So in 1957, again, this was the year that the 5-country study was published, Ansel Keys noted that each new research adds detail, reduces areas of uncertainty, and, so far, provides further reason to believe. But is that really true? I'm going to talk at length about the Framingham study later on and put it in the context of the 5 cohorts that were examined. But Framingham is far and away the most famous of them, and to this day we continue to learn things from the Framingham cohort. But the positive data showed that in the Framingham cohort there was a link between cholesterol and heart disease. A link is another way of saying an association or a correlation. The people living in Framingham, Massachusetts, who were who had higher levels of blood cholesterol were having more heart disease. The negative data, of course, were that in women over 50, cholesterol had no predictive value of heart disease. Now, there was a lot of unpublished data between the 1950s and the 1980s, and delayed publications on data and things like that. But one of the more interesting pieces of unpublished negative data from Framingham was, again, this is a cohort comparison that took several thousand patients, but compared 2 polar tranches of them. So they took the group of patients in the Framingham cohort who had serum cholesterol levels above 300 milligrams per deciliter. That's a very high number. From a percentile population, that would be in the top 5 percentile. They compared those men to those who had under 170 milligrams per deciliter. When they did that, they noticed that there was actually no difference in the amount of fat that they consumed. So it was interesting to note that they couldn't find an association, and typically this is a trick you do to call out differences, right? I mean, if you take the most stark examples, you can see these differences, but they couldn't even find an association, a correlation between what these men were eating and what was going on. There was considerable range of serum cholesterol within the Framingham study group. Something explains this inter-individual variation, but it's certainly not diet. And at the time, they didn't know what it was. More negative evidence when you look through multiple populations, so the Benedictine Trappist monks, Navajo Indians, Irish immigrants to Boston, the Swiss alpine farmers, the Maasai, the Inuit, other Africans, there was no association between the consumption of saturated fat to heart disease. Well, Ansel Keys rejected these as having no relevance to diet, cholesterol, coronary heart disease relationship in other populations. In other words, for reasons I don't entirely understand, these populations weren't relevant, but the other 5 populations were. Okay, let's revisit selection bias with a bit of a double click. In 1957, Oglesby Paul and his colleagues conducted an observation without an intervention. So they went to the Western Electric Company and they selected 5,400 men. I believe their ages were sort of 30 to 50-ish. And they didn't conduct any intervention. They just followed them. They just observed them. They didn't ask anybody to do anything except record what they were eating. And at 4 years, they published their results. The results were revisited 15 years later. They compared the 15% of men who reported eating the most amount of fat and contrasted them with the 15% of men who reported eating the least amount of fat. So it's sort of a similar trick to what we saw in Framingham. Let's take the extremes and ask what's happening. Worthy of comment is that when they followed these men over 4 years, of the 88 cases of coronary artery disease that occurred during that period of time, 14 took place in the group eating the highest amount of fat, 16 took place in the group eating the lowest amount of fat. In other words, there was actually no difference. Several years later, Jeremiah Stamler and colleagues returned to Western Electric and compared heart disease mortality and morbidity to fat content in the diet from 1957. So now they had a much longer period to follow up. And they concluded that the amount of saturated fatty acid in the diet was not significantly associated with the risk of death from coronary heart disease. In other words, they reiterated what was shown at 4 years. And so one of the criticisms of some of these studies has been you're never looking at a long enough period of time. So one of the big fallback positions has always been, well, you didn't notice a difference at 3 years or 4 years, but if we did this for 50 years, we'd notice a difference. Maybe so. But nevertheless, 15 years later, there was still no difference. But it was rationalized. Although most attempts to document the relation of dietary cholesterol, saturated fatty acids, and polyunsaturated acids to serum cholesterol concentration in persons who are eating freely have been unsuccessful, positive results have been obtained in 4 investigations besides the Western Electric study. Furthermore, if viewed in isolation, the conclusions that can be drawn from a single epidemiologic study are limited. Within the context of the total literature, however, the present observations support the conclusion that fat composition of the diet affects the level of serum cholesterol and the long-term risk of death from coronary heart disease in middle-aged American men. Well, the media liked that. And in 1981, the Washington Post reported, the new report strongly reinforces the view that a high-fat, high-cholesterol diet can clog arteries and cause heart attacks. Now, if that doesn't get your attention, I don't know what does. I mean, I would be scared senseless. Furthermore, one of the authors reported in the New York Times, the message of these findings is that it is prudent to decrease the amount of saturated fat and cholesterol in your diet. Let me remind you, their study showed nothing. Their study showed that there was not even a correlation. Let's take causation off the table. There wasn't even a correlation between the intake of dietary cholesterol and saturated fat. Now, they had an ongoing hypothesis, and they had 100 reasons why their study should have shown what it didn't show. But, you know, if we want to talk about ethics, we could also talk about the ethical obligations of the media. In 1990, of course, the denouement was upon us when the American Heart Association and the National Heart, Lung, and Blood Institute co-authored a report called the Cholesterol Facts, very official. And they stated that the Western Electric study is included as one of the 7 epidemiologic studies showing the link between diet and coronary heart disease that have produced particularly impressive results, and showing a correlation between saturated fatty acids and coronary heart disease. That's not true. So what's the state of the evidence circa 1970? Well, in 1970, the American Heart Association, now remember, we're going to jump back and forth in history. So by 1970, now Ansel Keys had the second study, the 7-country study. We still hadn't even started doing any of the trials we're going to talk about in a moment, but we had this observational epidemiology that had led us to this hypothesis. But the AHA committee recommended low saturated fat diets, less than 10% of calories, for every American, including infants, children, adolescents, lactating and pregnant women, and older persons. Now, a lot of people realized that something didn't smell right here. And it wasn't that people weren't speaking up. So it's really an interesting sort of clash of what almost turned into a religious discussion. And Henry Blackburn in the New England Journal commented in 1975, two strikingly polar attitudes persist on this subject, with much talk from each and little listening in between. And 3 years later in the New England Journal of Medicine, it must still be admitted that the diet-heart relation is an unproven hypothesis that needs much more investigation. So what about the clinical trials going on? Because we haven't talked about a single experiment yet, right? What we've talked a lot about are observations, correlations, associations. But let's start talking about clinical trials. Well, there were two clinical trials in the mid-60s that gained some prominence. One was a study in 1963 by a group of Hungarian researchers that randomized one group of patients to basically a no-fat diet, the other group to a normal fat diet, and they reported a benefit of consuming a maximum of 1.5 ounces of fat per day. But while that study was going on, a very similar study was taking place in Britain, but it reported no benefit of consuming a maximum of 1.5 ounces of fat per day. And the authors very sternly concluded that a low-fat diet has no place in the treatment of myocardial infarction. In 1973, a study was completed out of the University of Minnesota. This study would go unpublished for 16 years. The study randomized a group of 9,000 men and women to one of two interventions. The control group was to consume 18% of their calories from saturated fat. That's less than what I do, but nevertheless, that would have been considered probably slightly above normal for the day. The treatment group was instructed to consume 9% or less of their calories from saturated fat. So for about 4.5 years, two groups of people, about 4,500 in each arm, were on the same number of calories, the same amount of protein, the same amount of carbohydrate, but one group was eating high saturated fat, the other group was eating very low saturated fat. The low-fat, low-cholesterol group had 269 deaths over that period of time, whereas the control group eating the high amounts of fat had 206 deaths. As I said, these results went unpublished until 1989. And at the time, Franz, the lead author, commented as to why that was the case. We were disappointed in the way the results turned out. So what was the tipping point? Well, the tipping point was really, again, this is, you have to, it's almost like a drama, right? Because you've got sort of the scientific thing going on, you've got the policy thing going on. In 1967, Robert Kennedy was, as you know, getting ready to run for president, and he was somewhere in the South, either Mississippi or Louisiana, and he commented on how a lot of the children appeared malnourished. And so a committee was set up called the Senate Select Committee on Nutrition and Human Needs. And George McGovern was the single and only chairperson of this committee, which is why it often gets referred to as the McGovern Report or the McGovern Committee. So the committee was set up in the late 1960s to evaluate malnourishment in underprivileged populations. But within about 3 years, it quickly took a turn to focusing on the fat cholesterol thesis. And by 1972, everyone and their brother was standing in front of the Senate giving their rationale for why one approach was right or another. But in 1977, with tremendous pressure from Congress, the results needed to be finalized, something had to be published, and you'll recall what the comment was at the beginning of my talk for why they came to the recommendation they did in the absence of evidence, which is, in the absence of evidence, we have to be able to come up with something, and we don't have the luxury of time to know if we're right. But the two recommendations that came from this, which, I'm going to argue that there were sort of 3 or 4 crystalline moments that really shaped U.S. policy. This was clearly one of them. The recommendation in 1977 that Americans increase their carbohydrate consumption to between 55 and 60% of total calories, and that they reduce their fat consumption to 30% of total calories. Now, what was the fallback position? Well, the fallback position was something that we often all invoke, which is the precautionary principle. The question to be asked is not why should we change our diet, but why not? There are no risks that can be identified and important benefits that can be expected. This is by the late Mart Hegstead at Harvard at the press conference announcing this. Now, I'm sure we'll come back to this in a discussion, but I want to call this out, to be fair. There are some places where the precautionary principle makes sense. We have never done the most elegant study you would want to do examining the safety of seatbelts. Right? If you really want to do this experiment, what you do is you take 10,000 people, you put them in two groups, half of them get cars where they put seatbelts on, but the seatbelts don't work, right? Because you have to do this in a double-blinded fashion. So you've got a seatbelt on, but it's a joke, so if you hit something, you're going to go straight through. The other half have seatbelts that work. That's the real way you would do this, right? And we would look at automobile mortality over the next 5 years, and we could conclude one way or the other whether seatbelts are safe or not. That study has never been done, never will be done. We rely on the precautionary principle, which is there's overwhelming epidemiologic evidence, there's strong mechanistic evidence, meaning before we had seatbelts, people seemed to die by being flung out of cars. We now prevent that. And it was argued, for right or wrong, that the seatbelt does far less harm than the good it does. Now, maybe back in the day that was debated. I'm sure you could have made a case that the pressure on an organ from a seatbelt could have been overwhelming. So it's a fair point to make, but I want to call out, think about when the precautionary principle makes sense. Cigarette smoking is another. We have never done a long-term prospective randomized trial to examine the role of cigarette smoking and small cell lung cancer in the lung. In fact, and I'm going to allude to this a little bit later on, it's one of the few examples where observational epidemiology, in my humble opinion, is a very appropriate tool in health sciences. Why? You have to meet a couple of criteria. First, the intervention is very simple to measure and it's not multifaceted, meaning you either smoke a cigarette or you don't. It's very binary. Furthermore, the disease that's associated with it is almost unheard of in the population that doesn't do it. Small cell lung cancer barely existed until cigarette smoking came along. It's the same with asbestos and mesothelioma. We're talking about two very easy to isolate problems with very otherwise rare diseases. The precautionary principle would be very difficult to invoke here because coronary artery disease is quite prevalent in all populations, and furthermore, the intervention is very complex. Okay, let's take a step forward and look at the cohort studies. In the early 1970s, a couple of guys that I probably would have posters of in my room if my wife would let me, kind of the godfathers of the cholesterol world. These are the guys who really figured out how to do this. So Friedrichsen, Levy, and Lees basically came up with a very elegant technique to now fractionate cholesterol in the blood. So remember way back when we talked about how the crudest thing that we learned to do in the early 1940s was just take some blood out of somebody, separate out the cells from the plasma, within the plasma, undergo a chemical reaction, break apart every particle that carries cholesterol and measure the total amount of cholesterol. These guys figured out, using gel electrophoresis and other techniques, that you could actually break them into 5 particles that carry cholesterol in our blood. And we typically only talk about 2 of them, which are high-density lipoprotein cholesterol, which, as its name suggests, has the highest density, and low-density lipoprotein cholesterol, which, contrary to popular belief, is only the second least dense. But there are 3 others. There's chylomicrons, there are VLDLs, very low-density lipoproteins, and there are IDLs, intermediate-density lipoproteins. So you've got this spectrum of particles that decrease in density from the chylo to the VLDL to the IDL, LDL, and HDL. But these guys came up with an interesting technique, which is if you underwent a precipitation reaction in the plasma, you could separate out this thing that they identified as HDL, high-density lipoprotein. Furthermore, if you took the total amount of cholesterol, subtracted that out of it, and then took the triglycerides in the blood, which is the free-flowing fats in the blood, divided that by 5, you could actually come up with a pretty accurate estimate of this thing called low-density lipoprotein. And so the thesis was this low-density lipoprotein thing is interesting. That's where the money is. So to do this, the NIH became the first organization to ever fund a study that was now going to look at anything other than total cholesterol. And the NIH did this by funding 5 cohort studies. Framingham, which is by far the most famous, Albany, New York, Honolulu, San Francisco, and trying to blank it on the other one. Puerto Rico was the 5th. Okay. So 2 things were going on simultaneously that resulted in 2 landmark publications in 1977. The first was a purely observational view of how these cohorts behaved over a 5-year period of time. and they measured high-density lipoprotein, because they had to. The authors later acknowledged that they had no interest in HDL, but you had to measure it to calculate LDL, which is the thing they wanted. They similarly had no interest in triglycerides, but you had to actually measure the triglyceride to calculate the LDL. So that was the first study. The first study looked at these 5 cohorts and observed how well levels of HDL and triglyceride by default, but most of all, LDL predicted cardiac risk. And then the second thing they did in parallel to that was a prospective cohort assessment of risk prediction, where they now looked at the data they were getting from the cohorts and asked, specifically within the Framingham group, could we predict who was going to have a cardiac event as on the basis of what we learned? And here's what they learned. HDL, elevated HDL, was at best a marginal risk factor. More importantly, however, low level of HDL was a 4-fold better predictor of risk than LDL, and it turned out to be the only reliable predictor of risk for men and women over 50. The authors also commented on something else they observed. Saturated fat consumption raised HDL, and carbohydrate consumption, specifically sugars and highly refined grains, lowered HDL. In specifically the Honolulu, Framingham, and Puerto Rico cohorts, saturated fat and total fat negatively associated with the risk of heart disease. In other words, in this cohort examination, the people who consumed more saturated fat and total fat had lower heart disease. And the people who consumed more saturated fat and total fat lived longer. These are 2 common endpoints when these studies are done. They typically look at cardiac mortality and overall mortality. Over the next few years, a couple of other cohorts found other things. In particular, there was a Chicago cohort where it was found that low serum cholesterol, below 160, remember that's pretty low, was associated with a higher risk of cancer. This was actually observed in every study except the studies that were done in Chicago, which curiously, and perhaps by coincidence, were all under Jeremiah Stamler. The authors concluded, and again, this was referred to as the HDL shock. Things that raised HDL should be considered to reduce the risk of cardiovascular disease. Not what anyone expected. Now, keep in mind where we are. We're in the late 70s, early 80s. HDL and triglyceride got forgotten about for 20 years. In fact, it was only in the late 90s when Gerald Reaven at Stanford came up with this idea of what we at the time referred to as Syndrome X. It has since been renamed the metabolic syndrome. So we now are all quite familiar with what HDL is and what triglycerides are, and in fact, if you look at the criteria for metabolic syndrome, it's meeting 3 of the following 5. Low HDL, and I won't bore you with the cutoffs, elevated triglycerides, elevated fasting glucose, elevated truncal measurement, so central obesity, and elevated blood pressure. And if you have 3 of those 5, you've now bought yourself a world of risk for every one of those diseases I showed you on the first page. Not just the obvious obesity, but diabetes, Alzheimer's disease, cancer, neurodegenerative disease, fatty liver disease, non-alcoholic fatty liver disease, you name it, you've just increased your risk of every one of those diseases. And it's interesting to note that LDL is nowhere in there, nor is total cholesterol. It's really all about the HDL and the triglyceride and the glucose. But it went unnoticed for 20 years. Why? I actually really wondered this myself until I started digging into this with the help of Gary. It turns out that before the results of the 5 cohorts were published, the NIH had already undertaken 2 enormous studies, the largest studies ever done to that point in time, that were now looking at intervention studies to reduce the risk of heart disease. The first of these was called the Multiple Risk Factor Intervention Trial, or MRFIT. As a general rule, if you're going to do a study, it has to have a catchy name. This study cost $115 million, which in today's dollars is about $250 million, and it looked at 7-year mortality. Now, this study enrolled high-risk men aged 35 to 57. So these were men that were known to be at a very high risk for coronary artery disease. And there was one intervention group and one control group. So the control group was do nothing. The intervention group had 3 interventions. 1, they had to lower their intake of fat and cholesterol. So total intake of saturated fat had to come down below 10%, and dietary cholesterol, I can't remember exactly how many milligrams had to be reduced. 2, they had to stop smoking. 3, if their blood pressure was elevated, it had to be reduced with medication. So that was the intervention, that was the control, and at 7 years, 41.2 out of 1,000 people in the intervention group were dying of all causes versus 40.4 in the control group. And the Wall Street Journal pronounced this as a heart attack to this test. 2 years later, the other study that was going on in parallel, the Lipid Research Clinic Primary Prevention Trial, which unfortunately does not have a snazzy acronym, this one cost about $150 million, about $320 million in today's dollars, had a different intervention. This study took both men and women. I'm sorry, this study only took men, 3,800 men, and it randomized them into one of 2 interventions. The control group, which was put on a low-fat diet, so it's not really a control, but nevertheless, that served as the control, and the intervention group, which was put on a low-fat diet and put on a medication called a bile acid sequestrant. So this was the beginning of the medication for treating cholesterol period of time. These drugs are still used today, and they're very efficacious when they're used for the right things. At the time, no one knew how they worked. Today, we know very well how they work. Bile acid sequestrants downregulate the production of a certain type of molecule that carries something called apoprotein B. They also slightly increase the number of HDL particles. Nobody knew this at the time, but we knew that they were lowering cholesterol. So in this study, looking at 10-year mortality, the group that had the low-fat diet plus the drug had fewer deaths than the group that was just on the low-fat diet. Okay, that's a reasonably well-controlled trial, and assuming the internal validity of this was valid, was correct, you could conclude that diet plus drug was better than diet. However, Time magazine reported this as, sorry, it's true, cholesterol really is a killer. Again, interesting, perhaps true if viewed through the lens that wasn't known at the time that that drug did lower a certain type of cholesterol-carrying molecule, but it was a largely misleading message, and more importantly, the message becomes transmitted in a manner that's completely inconsistent with what the data showed. Now, the authors did conclude that caution should be exercised before extrapolating the LRC-PPT findings to cholesterol-lowering drugs other than bile acid sequestrants. And furthermore, they noted that the LRC-PPT was not designed to directly address whether cholesterol lowering by the diet prevents coronary heart disease. And that's true, it did not. However, Basil Rifkin, the late Basil Rifkin, the NIH director of the LRCCP, said in Time that year, it is now indisputable that lowering cholesterol with diet and drugs can actually cut the risk of developing heart disease and having a heart attack. And most of us in this room are probably old enough to remember. I remember this cover quite well in 1984, which was in many ways the final nail in the casket of fat and cholesterol. Rifkin went on to say that the LRC results strongly indicate that the more you lower cholesterol and fat in your diet, the more you reduce your risk of heart disease. So why'd they exaggerate? Well, as he acknowledged, it's an imperfect world, and the data that would be definitive is ungettable. So you do your best with what's available. This is really a variation on the precautionary principle. A couple of weeks ago, I write a blog about this kind of stuff, and someone asked a question about what book would I recommend to help really understand the scientific method, and I had to think about it for a couple of days. But I think the original work of Francis Bacon, which many people argue or would suggest at least was the cornerstone for the true development of the scientific method, would probably be a good place to start. In sciences that are based on supposition and opinion, the object is to command assent, not master the thing itself. So in 1984, the NIH Consensus Conference issued the following conclusion. There is no doubt that a low-fat diet will afford significant protection against coronary heart disease to every American over the age of 2. The Surgeon General at the time, C. Everett Koop, went on to say to this that the data proving the link between the consumption of saturated fat, cholesterol, and heart disease was stronger and more convincing than the evidence linking cigarette smoking to lung cancer. Now, I always appreciate what Dan Steinberg, who was actually the chair of the panel and the co-principal investigator on the LRC PPT, had to say about this. If there had been a true consensus, you wouldn't have had to have had a consensus conference. In 1989, the National Academy of Sciences, Diet and Health released a 1,300-page document, The Implications for Reducing Chronic Heart Disease. Highest priority is given to reducing fat intake because the scientific evidence concerning dietary fats and other lipids and human health is strongest, and the likely impact on public health is the greatest. It's as though there's data we're not seeing. Okay, let's talk about the evidence post-consensus. In 1990, which was really the apex of the low-fat movement in this country, a very famous physician named Dean Ornish and his colleagues published a study in Lancet, which was called the Lifestyle Heart Trial. This was published in 1990. This was a study that took about 56 men who had known coronary artery disease. There were a number of entry criteria. You couldn't have had a heart attack within the 6 weeks leading up to the test, but you were clearly a high-risk patient. And they were put into 2 groups. The first group was the treatment group, and the treatment included smoking cessation, a low-fat vegetarian diet that was not permitted to include more than 10% total calories from all fat, no flour, no sugar, stress management, and vigorous exercise. The control group was allowed to continue smoking, eating as they saw fit, not exercising, no yoga, eat all the sugar and flour you want. At 1 year, the patients were followed up. Now remember, this is a small trial, so there was no difference in the number of deaths. One person did actually die in the low-fat arm. He had a heart attack while exercising, but the study was not at all powered to detect that difference. The end point of this study was something quite novel, which is sort of what made this a very special study, which was they subjected all of these volunteers to coronary angiography. So at the beginning and the conclusion of the study, every patient underwent a very invasive procedure where a catheter is stuck into their femoral artery, dye is squirted into the arteries of the heart, and you take pictures, and from that you can tell how occluded the arteries in the heart were. Turned out the treatment group showed a significant reduction, about a 20% reduction in the lesions within their heart, while the control group had actually progressed about 5%. So this study was really viewed as a landmark because it showed that through lifestyle, without medication, you could reduce coronary artery disease. You could reverse atherosclerosis. The problem comes when you try to figure out what actually did it. Because there were really a heck of a lot of interventions here. You know, I tell the story sometimes, and I'm being a little facetious, but my background being in oncology, I think a lot about how cancer trials work and how good science, you tend to isolate variables. So it's sort of like me saying we're going to do a study where we're going to take 2 groups of patients with stage 3 colorectal cancer. In both patients, we're going to remove the lesion, and then in one group, we do nothing for a year, and then in the other group, we're going to do radiation, we're going to do 3 drugs, we're going to do daily massages, the visits from kittens, we're going to throw everything at them. And then in 5 years, we will find possibly that group in that arm did better. And that would be great if we kept our conclusion to what the data showed us, which is next time you're confronted with a patient with stage 3A colorectal cancer and you've done the operation, if you want to increase their chances of survival, you need to do these drugs, these kittens, these massages, these this, that. But imagine I came away from that saying, you see, drug number 2 is what's saving lives in colorectal cancer. That's exactly what was done here, and with all of these studies. Now, I don't know if any of you are familiar with the Cochrane collaboration. This is a group of 28,000 volunteers around the world. It's a nonprofit organization made up of scientists, physicians, folks who are interested in public health. And they have a wonderful mission, which is to take the complexity and ambiguity in science and try to distill it down to what is known. And so if the Cochrane collaboration gets involved in something, it's a really big deal. It's considered a significant problem. And so in 2001, the Cochrane collaboration published a meta-analysis titled Reduction of or Modified Diet, Reduced or Modified Dietary Fat for Preventing Cardiovascular Disease. They looked at 27 well-controlled randomized trials of 10,000 subjects followed for an average of 3 years each. And they concluded from this that no effect on longevity was observed, and there was no significant effect on cardiovascular events. Now, I'm personally very skeptical of meta-analyses. One of my mentors once gave me a great analogy, because a meta-analysis takes a whole bunch of studies and tries to accumulate them. And I remember once I was quoting some meta-analysis to him, and he said, you know, Peter, 1,000 sow's ears makes not a pearl necklace. So when you start with a whole bunch of junk, it's quite possible you don't get much out of it. So you always have to take a meta-analysis with a grain of salt. Nevertheless, 5 years later, they followed it up with a subsequent meta-analysis titled Multiple Risk Factor Intervention for Primary Prevention of Coronary Heart Disease. Now, they looked at two interventions, the lowering of blood pressure and cholesterol. These are two separate things, in 10 well-controlled trials that encompass 900,000 patient years of observations. And they commented or concluded that the pooled effects suggest multiple risk factor intervention had no effect on mortality. This is probably a study that most people in this room have heard of at some point. The Women's Health Initiative was really an enormous study. It went on for a number of years, and it examined a number of questions, including the role of estrogen, the role of calcium, the role of diet in the health of women. And many people have criticized it because it only looked at one demographic, which was, people ask me, like, how do you think of, like, the difference between men and women? And I sort of think of 4 different types of things on Earth that are humans. There are children, there are men, there are premenopausal women, and there are postmenopausal women. And I say that only based on my experience with how, and I'm not being a woman or a postmenopausal woman, I don't want to speak out of turn, but I have really noticed, and I think physicians in the room will also comment, that when a woman goes through menopause, a lot of hormones change in her body, and her risks really change from what might have been happening before. So the point I want to make here is people have criticized the Women's Health Initiative because it only looked at postmenopausal women aged 50 to 79. But nevertheless, within this population, they looked at nearly 50,000 postmenopausal women, and this was not a cohort, this was a prospective design, this was an experiment. And they divided them, so you got 25,000 women in each arm, and they were randomized to either a normal diet or a low-fat diet. And for 6 years, total fat consumption in the low-fat group had been reduced by 8%, and saturated fat had been reduced by 3%. They also, of course, had a commensurate rise in their increase in fruits, vegetables, and whole grains. The conclusions of this study, which were published in 2006 in JAMA, were that the intervention did not reduce the risk of coronary heart disease or stroke. A low-fat dietary pattern did not result in a statistically significant reduction in the risk of invasive breast cancer. There is no evidence that a low-fat dietary pattern intervention reduced colorectal cancer risk. And the low-fat dietary pattern among generally healthy postmenopausal women showed no evidence of reducing the risk of diabetes. So we've got a little bit more to go. We're almost done. It's warm in here. I feel it as much as you and more. But I want to talk about a couple of other diet trials that have been often talked about in the media. So one of them was published by Foster and colleagues in the New England Journal of Medicine in 2003. Now, you got to remember what was going on in 2003. So most people think that Atkins kind of came along at that time, but actually Robert Atkins had been around since the 60s. And in fact, if you ever want to be shocked, I recommend looking up the Senate hearing of Robert Atkins in front of the McGovern Commission in 1972, because by that point, Robert Atkins had an enormous practice in Manhattan where he was treating patients with diabetes and obesity with a low-fat diet, a low-carb, high-fat diet, and he was being viewed as an assassin, effectively, a clinical assassin. And he spent a lot of time in front of that group. But nevertheless, in 2003, there was a real resurgence of the Atkins diet. And as a result, this prompted some interest around clinical investigations. And the first of these was done by Foster. This took a group of 63 obese men and women. They were randomized into 2 diets, your conventional low-fat diet and a high-fat, low-carb diet. These were consuming the same number of calories. This group, this study found at 6 months a significant reduction in weight in the low-carb group, but by 12 months that had vanished. And this is very common in these studies. You'll tend to get everybody loses weight at the beginning, and then it narrows with the recidivism, and people are not as compliant. But interestingly, at this point, people were starting to say, well, so what? I mean, okay, eating fat might not make you fat, although most people still believe it does. But clearly it leads to heart disease, right? So, the line offered by Dean Ornish at the time was, look, if it's all about losing weight, you can take up heroin, right? It's about health, right? And I agree with that. It's about health. I mean, weight is just one proxy for health. But anyway, let's take a look at health. So you'll recall from our discussion about what took place in the late 70s and early 80s, and what was then reemphasized in the late 90s with the sort of elucidation of metabolic syndrome, that the two things that are completely irrelevant is your concentration of LDL cholesterol and your total cholesterol. The two things that are probably relevant is the concentration of your high-density lipoprotein cholesterol, HDL, and your triglycerides. And what do we find in this study? Even with modest compliance, the group that was on the low-carb arm compared to the low-fat arm had a significant increase in their HDL and a significant decrease in their trigs. There was no difference in LDL, and there was a slight increase in favor of the low-fat group in total cholesterol. One of my favorite studies, probably because I know the author personally and have spent a lot of time talking about it, but also because I think it's a very interesting study, and it was a very well done study, is the A to Z trial. And it's, as you can see, A is Atkins. Anyway, the point was this was a study that took about 80 people in 4 different arms, so about 300 people, and these people were now randomized to one of 4 different diets that spanned the entire spectrum of dietary intervention. So on the one hand, you had the Ornish group that was eating 0 saturated fat, all fruits, vegetables, whole grains. At the other end, you had the Atkins people on bacon, eggs, cheese, and then you had the Zone group, which was 40% carb, 30% fat, 30% protein, and then you had Learn, which is effectively the sort of USDA DASH diet. Now, something to note about Christopher Gardner, who, by the way, there's a fantastic lecture online that he gives on YouTube when he first presented these results. Christopher is a vegan, and he commented to me, and he's commented publicly, that the results of this study were upsetting and shocking to him. Because as a vegan, he eats an Ornish-like diet. Now, Christopher does it for, sort of ethical reasons, not necessarily health-related reasons, but nevertheless, he found this very shocking. And as you can see, the Atkins group, which, by the way, when you look at the compliance between 2 and 12 months, you can see how everybody kind of moved back together. So at 2 months, the Atkins group was truly a low-carb, high-fat group, and the Ornish was clearly, doing their best to be low-fat. But you can see that by the end, the Ornish group was effectively eating, a greater amount of fat, et cetera. The Atkins group had crept back in their carbohydrate. But nevertheless, the Atkins group experienced a significant reduction in actual weight loss, in reduction of triglyceride, increase in HDL, and reduction in diastolic blood pressure. Another trial that was done 2 years later, 1 year later, was the diet trial called the Workplace trial. This trial included 322, I think, obese, I think it was just men, and they were randomized into 3 groups, so about 100 people per group. And this time there had 3 dietary interventions. So a third of the people were put on a low-fat, calorie-restricted diet. A third of people were put on a Mediterranean, also calorie-restricted diet, and a third of people were put on a low-carb ad libitum diet, meaning you can eat whatever you want as long as you don't eat carbs. What you see here is the intervention over 2 years by month on their weight change. And again, there's this very typical pattern where a lot of people kind of drop their weight, and then at about 6 months, people tend to slip back into the former, there's this convergence again. But nevertheless, you can see that the low-carb and Mediterranean group had a significant reduction in weight loss relative to the low-fat group. And when you looked at biomarkers in blood, now this table is a little confusing, let me explain the colors to you. Red means it was a significant change within the group from their baseline. So when you took, for example, in the low-fat group, they actually had a significant reduction in their level of systolic blood pressure relative to where they were when they started. Green means no significance, and purple means it was significant across the group. So, for example, the rise in HDL, high-density lipoprotein cholesterol, in the low-carb group was not only significant relative to where it was in the beginning, but was significant relative to everybody else. And so you can see here that everybody experienced a benefit in blood pressure. Nobody really experienced a benefit in LDL change. Everyone experienced a benefit in HDL, but most of all in the high-carb group. And again, think back to what was discovered in the first cohorts of Framingham based on that lipid analysis, which was the people who were eating the most fat and the least sugar and grains and highly refined carbohydrates had the highest HDL. So this shouldn't be surprising. The same thing is true on the triglyceride side, and obviously your total cholesterol to HDL ratio, which really isn't that important, but people seem obsessed with it. It's also worth noting that the hemoglobin A1C, which is a pretty early predictor of diabetes, was only significantly reduced in that group as well. So, that's kind of it for the talk. I've got a couple of slides left, but people often ask me at this point in time, it seems like what you're saying is too ridiculous to be true. How could this have taken place? And I really divide it into two categories. There was the pre-1984 rationale for all of this. And I say, why the confidence? Well, before 1984, this almost religious zeal and belief and conviction that fat must be bad was really based on observations of populations that consumed low amounts of fat. So when we looked at populations that consumed little amounts of fat, we noticed that in some of those cases they had no heart disease. We couldn't get off this fixation. Now, it's long acknowledged since that time that there's a whole bunch of other things they weren't eating. They also didn't eat any sugar. So when we talk about contrasting the wealthy people that were eating all the fat and the poor people that weren't, well, they also weren't eating sugar and they weren't eating a whole lot of other things as well. Post-1984, I would say that the greatest issue leading to the overzeal of confidence probably has to do with the cholesterol-lowering drugs, which no doubt, from a secondary prevention standpoint, have in most cases reduced cardiac mortality. In other words, there's no evidence of this in primary prevention, but for secondary prevention, when you take people who are at known risk or have had heart attacks and you put them on medications that lower cholesterol, we do see their numbers getting better, and we also see their risk of subsequent disease getting better. But it's really important to keep the following in mind and never forget this. Drugs and diets are not comparable. Drugs have multiple actions, as do diets. And to say that a statin reduces a heart attack because it lowers your serum level of cholesterol is like saying that aspirins reduce heart disease by curing headaches. Aspirins do a lot of things. They thin out platelets, and that in some people reduces the risk of heart disease, but they also get rid of headaches. There's no causation there. And so while it is true that a lot of drugs happen to lower some fraction of cholesterol one way or the other, it says nothing about what they're doing to heart disease risk. And I'll close with sort of one of my favorite quotes. For the greatest enemy of truth is very often not the lie, deliberate, contrived, and dishonest, but the myth. Persistent, persuasive, and unrealistic. Too often we hold fast to the cliches of our forebears. We subject all facts to a prefabricated set of interpretations. In other words, we enjoy the comfort of opinion without the discomfort of thought. And I would offer that that's exactly what's taken place over the last 60 years. So thank you for your attention.